Okay. So this is the Ph.D. Learn Show. You all are probably familiar with the Ph.D. Learn Show now as professional students. At the bottom of the screen is where this announcement was that went out this morning, just telling you that we got class today. I'll make this bigger so that most people like me can see it. So on the margin here, if you go under course content, you'll get the syllabus in this folder. Here's our syllabus, just to show you what we went through. Okay. And then you can go back here to course content, and you can see weekly tasks, lectures, pre-quizzes, and post-quizzes. Here's week 1. Here's our first lecture, Introductory to Pathology. Okay? I should turn edit mode off. So this is what you'll see. You won't see all that other stuff. You're going to see this right here. If I go back to the week 2, it's empty because there's nothing happening next week. If you go to week 3, cell injury and death, here's your material. Okay, so your PowerPoint up top, your pre-quiz due 9:10 by noon, your post-quiz due 9:14 by 11:59 p.m. Okay? And this is week 3. If you go back to course content, you go to getting started, you go to syllabus, you can see that this is week 3 right here. Oops. I don't know why. There it is. Okay? So everything lines up. So that's the whole semester. Questions?
How many questions are on the quizzes?
5 questions on the quizzes. Okay? 30 minutes each. Once you start, you want to finish it in one sitting, one experience, whatever the word is. Okay? And if you get kicked out, like at a coffee shop, if the Wi-Fi is bad, try to log right back in. It should let you right back in. Okay? Any other questions? No code. Someone email me. I don't have a code. I don't care. I built all the questions in Ph.D. Learn so you don't have to buy anything. Okay? You're welcome. Okay? I mean, you have to pay me $65 a semester. I forgot to mention that. There's no code. So don't buy a code. Don't get suckered into buying a code. Okay? You can buy a used book. You can probably find it on Amazon. 8th or 9th edition. How many found, let's see, who got the cheapest book? This is always the contest. Let's see, how much?
$18.99.
Ooh, that's pretty cheap. Yeah, $18.99. Who else? Anybody beat $18.99? Going once, go in the back? $6.50. $6.50. Does it have pages? 8 books. Okay, see, that's why I do it this way. It's like you're not paying $125 for a book. And then, oh, you need a code for another $115, right? I know. So this is cheap, right? You're welcome. All right. Let's see what else. Yeah, it takes, I know it sounds, I'm not trying to be arrogant about it. It takes a long time to get it done. So don't give your other professors a break. I mean, the reason that we use codes in other classes is because it takes time to get all these things in place. And so if you've been doing it for years, then you have built the time over the years to do it. There's a couple of key ones like week 9. You have 2 pre-quizzes and 2 post-quizzes. You see that? Okay, so there's just a lot of content. So it's 5 in each quiz. So there's 2 quizzes that are pre and 2 quizzes that are post, same times. Okay, there's one more week during the semester that it's that way. I think it's week 15. Week 15, 2 pre-quizzes and 2 post-quizzes. Okay, it's just the way that the semester lands because we have Labor Day week and we have Veterans Day, and they both fall on a Monday. So we actually lose 2 weeks this semester because it falls on a Monday. Okay. All right, so let's go into week 3. What's it going to look like when you click on this? You're going to usually get a screen that looks like that says the test has a time limit of 30 minutes. It'll save and submit automatically, okay, when the timer expires. Let's see. It tells you the due date, and then to begin, you click begin. Okay, and there'll be like a timer that comes on. Okay, and there's a test bank. You'll have 5 questions that are pulled from the test bank. Okay, Okay, so you may not have the same question as the person next to you on their laptop as you're looking at each other's screen. It's not the point. The point is for you to do this independently. Do your own work. Can I manage and monitor that? No, other than they're random questions and you may not get the same questions. But you're only doing yourself a disservice because the whole point is to encourage you to learn, not to see if you can actually copy your neighbor efficiently. Okay? That's not the way it's supposed to work. So it's up to you. Can I police that? No. Can I police that in an exam in this classroom? You betcha. Okay, we'll have proctors in here and you're gonna have to do your own work. But on the quizzes, yeah, it's an honor system. Again, but it goes back to that, be true to yourself. You're only cheating yourself out if you're not actually really trying to learn the work. Questions on the pre and post quiz. Questions on where to find the lectures. Let's just click on the lecture. Week 3. Oh, let's go to this week. Week 1 introduction. Right. So here's the lectures that I'm. Okay, that slide look familiar? So all the lectures are here. You can print these out, okay? In the BB Learn announcements, if you click on more announcements, you scroll down, there'll be a section that says how to print PDFs, multiple slides per page, right? If you want to print like 3 slides per page with lines for notes, a lot of students find that very effective is you print out these pages and you bring in the class and you take notes right on the slide because that's going to build my test questions, okay? Yes, it's a little bit more expensive, but if you spent $6.50, I think you could probably afford to pay for some printing this semester, okay? If you spend more money than that, you got a tablet, you can just take notes on your tablet. If you've got that fancy software, no problem. There's lots of different options. But having those notes and looking at those notes and bringing them to lecture and actually taking notes on the slides is a great, effective way to study, okay? Get through the class. Any questions? Yes?
Are the bank of questions that you have the same for the pre and post tests?
No, they're different. The question is, are the bank of questions for the pre and the post test the same? They're different banks of questions. The post quiz questions are intentionally a little bit more challenging. That's a fancy way of saying you're going to be frustrated with me when you see some of the post quiz questions. You're like, really? You didn't go over that? No, I didn't go over it. I don't have it in my book. I'm trying to make you think. Yes, I'm trying to make you think. Based upon what you know, based upon what you've learned, based upon what else you can find out there, okay? It's the patient is presenting with unique symptoms you've never seen before. Figure it out. You're going to have to do that for a living, so let's start practicing it now, okay? And you're like, well, I'm not going to be a doctor. Well, guess what? Life throws you curveballs all the time. You're going to have to figure that out in other areas of life, okay? It's called problem solving. So, the pre-quizzes are going to be a little bit more boilerplate, and the post-quizzes are going to be a little bit more challenging. And so when you experience that, you'll remember, okay, yeah, he did say that. Okay, so they're different banks of questions. Does that answer your question? Yeah. All right, I want you guys to think about this quote. Give a man a fish, feed his family for a day. Teach a man to fish, feed his family for a lifetime. So think about that quote, and then I want you to turn to your neighbor, maybe introduce yourself, and share answers. Let's see what you guys come up with. Ready, set, go. Yeah, so how many of you had the exact same thing as your neighbor, essentially? The meaning was the same. Raise your hand. Meaning was pretty much the same. Raise your hand. Okay, so how many had it that was mostly different? It was actually quite different, your two definitions. Okay, so how many of you did participate in this exercise? Just raise your hand. Okay. All right, so you're talking about the hurricane in Hawaii or something else. Okay. The point of this activity is that you're probably not going to always have the same interpretation of the information, of the data that's sitting in front of you. Okay? So let's hear one bold volunteer's explanation of what this proverb is referring to. Here, just shout it out. Go ahead. Yes, sir.
So basically, if someone gives you something, it's an instant type of gratification, whereas if you hone down a skill or you get something that you learn over time and work for, it's a gratification you get for the rest of your life.
Okay. So a lifetime of gratification versus instantaneous gratification. Everybody have the same interpretation? I agree with that. Anybody have the same interpretation, or anybody have something a little different? Xander. In terms of health?
Yeah.
Okay, health?
Yeah. Like give a man a pill to treat a symptom of
Yeah.
disease or teach him how to be healthy.
Okay. In the terms of health, you could give someone a prescription, medication, give them a pill to make them feel better, or you can try to teach them maybe lifestyle changes or influences that can help them for the rest of their life. Okay? Anybody else? Those are the only two interpretations in this room of 100. I find that difficult to believe. Yes, sir, in the front.
I would say that both are rewarding, but going on what he says, there's a lot more rewarding if you teach them a certain skill rather than just handing them over to him and then using it for a very short time.
Okay, so a little bit more leaning towards the first example, which is if you can teach somebody a skill set, then there might be longer term value, right? Anybody else? Something out of the box, something completely different. Right here.
Knowledge is worth more than things.
Knowledge is worth more than things, okay? That's a very different way of looking at it. I agree. Knowledge is power. In the back, Bill?
Giving a man a fish is fine, but if you teach him to fish, he gets lost of potential customers for life.
Okay, so definitely more of a business angle here. Okay, losing customers is bad, so don't teach people how to fish. Okay?
Have a class and hey,
Unless you have a class, and then you come to my class and learn how to fish, right? Then I can benefit from those customers. Very good. So, yeah, and a flip of that is, some would argue in academics, you're training your future competitors. I had this conversation with my Ph.D. advisor when I was in grad school. And he said it's an interesting field because you're actually pouring so much into students, and then if they become your grad students, you pour so much into these graduate students, and you're training your future competitor. Right? That's what you're actually doing. And they're going to go after the same grants as you, or they're going to work for the same companies, or they're going to start competitive companies in some cases. So why would you do that? Well, maybe it's bigger than that, right? Maybe it's bigger than self-preservation, and it's all about trying to encourage like the next generation of thinkers and learners. And you potentially I'm training my replacements here, not necessarily my competitors, but after I'm done, you all are going to move on. And that's, as a teacher, that's why a lot of people teach. You're training the next generation. So there's another saying that says, any ideology is one generation away from extinction. You guys like that one? Any ideology is one generation away from extinction. So if I don't do my job about getting you all excited about this particular microclimate of science, then I'm not serving the future well, because it might just dissolve. So that would be my interpretation of this saying. So when you get together in your SI groups, you're not going to be talking about Chinese proverbs, okay? It's not. But the point is, You're going to be talking about pathology and the diversity in this classroom, your backgrounds, your experiences, your life experiences, not only your coursework, what you want to do in the future, your families. All of that's going to influence the way you see things. And you might be surprised. You might be learning just as much from your SI colleagues as you do from me. Okay? And so I want you guys to have an open mind when it comes to studying in these groups. Okay, and that's the point there. All right. I really want you to start study groups. And the last thing is we have this tradition, and this started a long time ago, because I was trying to figure out how in large classrooms, this classroom used to be like 30, 40 students, and now it's like 100. And I used to teach larger classrooms, and I think the peak was like 201 was in Klein Library. I was the first one in biology to move lectures into Klein Library way back when. And so there's 407 seats in Klein, because I counted them all. And number of semesters, we had 407 students in there. And so keeping students engaged is hard. And I'm not really that funny. So I asked my kids, how could you help Dad be funny? And so they decided they were going to write jokes for me. And so I have a stack of dad-like jokes that we go through, okay? And so we usually kick off the lecture with it. I bring my jokes with me. And so I'm just going to go through 3 jokes right now, and we're going to go back into the real lecture. You guys ready? Yeah. Okay. And these are all usually pretty clean. I mean, some of them have bacteria in them, but other than that, they're pretty clean. Like bacteria in the joke. That's what I mean. Sorry, not funny. But they're pretty G-rated. Many of them my children wrote when they were a lot younger. Now my oldest is almost 16. I know, and my youngest is 9, and then there's 2 in between. But they were writing them, like 10 years ago, they were giving me jokes. And so you kind of tell, if they're not super funny, you kind of have to laugh because it's being recorded. So that they don't feel like, oh, that was a bad joke. Okay. All right, why do most fish live in salt water? Why? Because they're allergic to pepper. What did the pen say to the pencil? So what's your point? I know who took that one. What does a peanut say when it sneezes? What does a peanut say when it sneezes? Cashew. All right, you guys ready? Right? We're going to go and transition into sort of a real lecture. Okay, our first content. So I want you to turn to your neighbor. One of you define pathology, and one of you define epidemiology. These can be 2 of the words that we start out in our quiz. You're like, I didn't even get the book yet. I'm like, I know. Okay, what do we have? Brave soul to volunteer, define pathology. What is pathology? You ready?
Study of suffering.
Study of suffering. Nicely done. That's what it literally translates as. Study of suffering. Yes?
Biological pathways of diseases.
Biological pathways of diseases. So another interpretation of study of suffering, that's the literal translation, right? Would be the study of diseases. And so underneath the category of the study of diseases, like Oscar says, it could be these mechanistic processes that are underlying the disease. Okay? It's pretty good. You guys you're spot on. How about epidemiology? This one's usually a little bit more challenging of a term to define. Who has a definition for who? Let's go with somebody new and we'll come back. Ladies first, how's that? Epidemiology, the study of the causes of diseases. So not exactly causes. Causes might be part of that process, or the causatory events. But really, from a cause and effect standpoint, we're really going to be looking at etiology is the word that's causation. Okay, very similar to epidemiology. Do you have something, or we'll go in the back?
The study of the spread of diseases.
The study of the spread of diseases. Okay, or the study of factors and illnesses that lead to the spread of the disease. Okay, so cause up front, etiology is cause, and we'll get to etiology in a second. So a virus infecting a tissue may stimulate a pathology. That would be etiology. That would be a cause and effect. Does that make sense? Whereas epidemiology might be, okay, let's look to see if malaria, if we have a malaria outbreak in this particular country, and we track its migration in different populations, where does it go? So you may not even know what malaria is or what caused it. You're just studying where's it spreading to, and maybe how can I prevent it from spreading. Okay, that would be epidemiology. Okay, we're going to get into a lot of terms, and one of your first SI sessions is going to be about some of these terminologies. Okay, and you'll see these up there. I want you guys to jot down 5 different diseases. It could be anything. 5 different diseases. Typically, if you've got something that you wrestle with, that usually goes down on top of the list, or if a loved one has a disease, or maybe you read the paper. Nobody reads the paper anymore. Maybe you saw it on a post, okay? Saw it online somewhere. Let's write down 5 diseases. As you're writing down these diseases, I'm going to keep talking. Okay, so a disease broadly refers to a condition that impairs normal function. That's the broad definition of disease. Okay? So there are psychological diseases, right? There are mental impairments. Maybe that wasn't even on your radar. There are behavioral diseases, right? Probably in the category of psychological. Now, we don't talk a lot about those in this class. Okay? Out of the Department of Psychology, you probably would cover a lot more of those types of diseases, behavioral or psychological diseases. Could be a category of diseases that are infectious, right? But not all diseases are. But cancer is not an infectious disease. It is definitely a disease. You cannot catch cancer from your neighbor. Okay? How about this word? Illnesses. Are they diseases or sickness? Illnesses and sickness are usually referred to as general symptoms associated with certain types of diseases. So there's some underlying disease and there might be an illness or a sickness related to it. You have a thyroid issue. If you're hypothyroid, right? The illness or the sickness might manifest itself in low metabolism. You're always feeling sluggish, tired. But the sluggish or tired is not the disease. That's the illness or the sickness. Okay, let's hear some of your terminology. So those are great words to put on our flashcards, all these ones that we're talking about. Let's just do popcorn. So say it, let me have a chance to comment on whether we're going to cover it or not.
Diabetes.
Diabetes. Okay, diabetes. Yeah, type 1 or type 2 diabetes. We're actually going to cover both of those in our endocrine section this semester.
Alzheimer's.
What it? Zeta?
C. diff.
C. diff. Oh, C. diff. No, C. diff. We will not cover C. diff this semester.
Alzheimer's.
Alzheimer's, we'll cover Alzheimer's this semester. What? Tuberculosis? We'll brush on it a little bit in the respiratory section.
Malaria.
Malaria, I brought it up, we won't even cover it, other than what I just said, right?
AIDS.
That's Palmer. AIDS, we will cover AIDS a little bit. Okay? Glycogen storage disease, we will not cover that this semester. What else?
Sickle cell.
Sickle cell anemia, we won't cover that this semester. You probably covered 181, 182, I'm guessing.
General STDs.
General STDs? No, other than HIV. What else? We won't cover any other STDs. Myasthenia gravis, we'll cover that one. Tara was going to say something? Yeah, we won't cover Harlequin. Anything else? What's that? Autoimmune, we'll cover autoimmune diseases. So the point of this exercise is we could sit here probably for a 2-hour segment and just list diseases. Okay? And so this class is called General Pathology. So we're going to cover some of the major systems, and we're going to cover some of the biggest ones in those systems of diseases, and maybe the disorder that follows. But I just want, the idea is to get you some overall general exposure. What would be valuable, I think, just as a review, next week, before the following week, I would actually encourage you to write down the primary organ system that's affected by just the disease that you have on your paper. Okay, the 5 diseases. Write down the primary organ system that's affected. If there's multiple, go ahead and list them. List the ones that it affects. Okay, so like diabetes, for example. Diabetes, you could write down pancreas if it's type 1. You could write down muscle. You could write down cell, right? You can write down bloodstream. You could write down blood vessels. You could write down nerves. You could write down eye. All of those organs are affected systemically by unmanaged type 1 diabetes. Okay? This is just good warm-up to give you, I mean, again, the prereqs for this class are vast, right? You got 181, 182, 201, 202, and 205, which is micro. So 201 and 202, you probably will recall mostly for this class, but it might have been a few semesters or even maybe a couple of years since you last took it. So refreshing yourself on the organ systems is not a bad exercise or activity. This could be an SI session activity as well. Okay, so now let's define some more terminologies, and we already have the terminology of etiology described. Etiology is what? What is etiology? The cause of a disease, the causation. Okay, what started the whole thing? So the origination or the causation, it's derived from a Greek term that means giving a reason for, etiology. Pathogenesis. Okay, so Oster alluded to mechanistic pathways. So the pathogenesis is really referring to the disease and the mechanism by which the disease facilitates. Now we move into morphological alterations. We're going to see both gross changes, right? That's macroscopic. The word gross means macroscopic. Okay, not disgusting. Everyone thinks that gross anatomy is like disgusting anatomy. That's what no, it's referring to macro view. Okay, large, gross macro view. And then microscopic, where you're looking at the cellular level or at the tissue level. Or in some cases it might be subcellular. We might actually in this class, we will, in some of these diseases, we'll go into those mechanisms at a subcellular level of what's happening inside the cell. Like when we get into the cancer section, we'll talk about some of the mutations that take place within the cell. And then last but not least, we're going to reference the clinical significance. This is the who cares. This is the part of the class that sometimes is the most interesting, where we start understanding and talking about, what are the symptoms, what are the clinical manifestations or the clinical sequela of that particular disease. What's that?
Also a favorite response to questions.
Also a favorite response. Many different types of students, correct. Okay, so the first disease example that I want to capture today is one referred to as Barrett esophagus. Okay, Barrett esophagus. So there's four main aspects of the disease. Barrett esophagus, let's see, I have to remember to bring markers. Do you have some dry erase? Yes, you. Oh gosh, you're such a nerd. Thank you, Taryn. All right, so four main aspects of the disease. Barrett esophagus. Number one, many of these patients suffer from gastroesophageal reflux disease, otherwise known as GERD. Okay? Gastroesophageal reflux disease. 10% of these patients move on to Barrett. Is it 2 R's? Yeah. What is gastroesophageal reflux disease?
Excess stomach acid.
Heartburn, thank you. Excess, yes, and yes. Okay, both of you are correct. Heartburn. Excess stomach acid that isn't contained within, that may not be excess in the sense that too much is being made, could be. It's usually a problem with that esophageal sphincter. And it's the lower esophageal sphincter. Right, if you remember back to, this would have been in 202, right? In the digestion section of 202, there's an upper and a lower esophageal sphincter. And that lower esophageal sphincter is what closes off and keeps the stomach contents within the stomach. And as the stomach goes through chemical digestion as well as mechanical churning, there's sloshing that takes place. And hydrochloric acid is being secreted, right, at the level of inside the stomach. So if that sphincter at the bottom of the esophagus doesn't shut tightly and well, you're going to get some leakage that comes back up the esophagus. And the esophagus lining is what type of microarchitecture? What type of cells line stratified squamous epithelium, right? Because you're chewing food, you swallow the bolus, and there's a lot of abrasion, so you want something that can handle the abrasion. But they're not designed to block or deal with that acid. And so it irritates that lining, and that's why you get the sensation of heartburn. Because the esophagus runs right down the center of the chest, right? There's nothing to do with the heart, it's just, that's what we call it. Okay, so number 3 is prolonged injury to the esophagus. Right? That's prolonged injury over time. And that's a chronic situation. So number 3 is chronic. And then what happens over time, so all of these kind of feed into each other, right? Those cells go through a change at the level of the esophagus. They go through what's called cellular metaplasia. So here's another vocab term. Metaplasia. So what is the word metaplasia? What do you think that means? Does it sound bad? Yeah, it kind of sounds bad. But what does the word really mean? In the very back.
Metaplasia is where the cells are changing to different cells to
So metaplasia is the cells change or they differentiate from one cell type to another. Okay, metaplasia is a Greek word, and it means change in form. That's in the Greek. A lot of Greek, a lot of Latin. So they change in form. So it is reversible at this stage. It's a reversible replacement of one differentiated cell into a different type of differentiated cell. And this is our first disease example of the semester. So we're going to talk more about GERD. We're going to unpack GERD, and we're going to go down a couple of different rabbit holes as we wrap up today. Okay? So chronic GERD. So 10%, we said 10% of patients that have GERD develop Barrett. Why is it only 10%? We don't know. That's just what the numbers are. Okay? If we follow the epidemiology of the disease, that means we follow the statistics. That's another great way to define epidemiology is you're looking at statistics about diseases. Whether it's statistics about prevalence, about ethnic classes that it targets, about gender, right? And people are, oh, can you say those things? Yeah, I can say that, 100% of females do not develop testicular cancer. Okay? There's nothing insensitive about that statement. Okay? It is what it is, right? So, or prostate cancer for that matter. Okay? So we can follow epidemiologically. We can follow different races, different ethnicities. We can follow different genders, men versus women, right? We can follow statistics. I don't know why. We don't know why only 10% develop GERD. Probably because they're predisposed to it, right? 90% of the population doesn't develop Barrett as a result of heartburn or GERD, but it's definitely a risk factor for the development of Barrett. Now, Barrett isn't the problem where it's reversible. It's reversible cellular metaplasia. The real problem is this is a predisposition for esophageal adenocarcinoma. Okay, so esophageal this is a form of cancer. And so now you're talking about esophageal cancer. And we're going to see this motif. This is why I love using this example, first day of class, is in a lot of these pathologies, we've got the following recipe happening. We've got damage to a tissue bed or a population of cells. And that damage is over a long period of time. And the cells are going to respond to it. And as they respond to it, they try to adapt and they try to change. Okay? They try to evolve. And that long-term damage could cause them to change or to evolve into something that's pathologic. Cancer, for example. Okay? And so that is a very, very common theme that you're going to see. And as you've got this, I'll get your question in one second. You've got reflux disease, heartburn, right? You've got prolonged injury to the esophagus, chronic over time, and that's irritating that esophageal lining. And the esophagus tries to respond by changing the architecture of the cell from a stratified squamous epithelium to a goblet cell containing epithelium. And as it changes, right, it's mutating to a different form. And as it mutates, there's inflammation that's there, right? There's swelling that's there, and this could lead to future pathological conditions like esophageal cancer. Okay, question over here.
I'm pretty familiar with this, but I thought you can get like scabbing from this, and that they have to scrape, like surgically scrape.
You
My
can.
grandfather just got diagnosed with this.
Yeah, you can. So the question was, or the comment was that in some individuals you'll get scabbing that'll line the esophagus. I'm going to show you some pictures here in a second. I don't have scabbing pictures, but that scabbing that takes place is because of that inflammatory burning action. Basically, you're causing a chemical burn on the inner lining of the esophagus. So it would be just like if you took hydrochloric acid from the lab and poured it on your hand, like a drop every couple of days. You're going to see a result, right? And it may actually scab over, right? Not everybody does that, but if it does scab over, it actually can narrow the esophagus, and they might have to come through and clean it out. Okay, but the underlying etiology is that you've got a weak sphincter at the bottom of the esophagus. Okay, great comment. All right, so here's a picture. This is a picture down the esophagus. Now, the left image is healthy. Okay, the left image is healthy, and the reason that you know that it's healthy is that stratified squamous. So this is a scope that's going down the esophagus, and all the way around the tube, you can kind of appreciate this white shiny or glistening epithelium. And that's what stratified squamous looks like. Okay, it's moist, it's slippery. That's what you want to have happen when the food goes down, right? You want it to actually nicely drop into the stomach. That's the whole point. Here, you've actually lost a lot of that stratified squamous epithelium. It doesn't look nearly the same. And the additional redness is because that tissue is inflamed. So here is a more progressive lesion. This is actually an esophageal adenocarcinoma that's found within the esophagus. The morphology has progressed. This is a polypoid mass. And they would come in and take a biopsy, and they would look histologically at that tissue, and they would determine that it's an adenocarcinoma. Okay, so you have throat cancer, and that's the diagnosis that would take place. Okay, now the good news is it's not typically at this early stage. It's not extremely aggressive, right? It's well formed. It's in a nodule. It's probably not going to metastasize and break off right away. And so the idea is remove it and get rid of it, right? Maybe cut out some of the healthy margin or healthy tissue around it, and try to prevent it from spreading. Okay? And we'll save some of these conversations for future rabbit holes when we get down into like the cancer lecture. But I just wanted to give you an understanding of what these lesions look like and how they can progress. And so this is gross pathology that we're looking at, right? This is at the macro view. And if we want to look now down at the level of the histology or the microscopic view, if we follow those principles that we're talking about, this is what our histology is going to look like. So we've got microscopic metaplasia, which is our number 4 on the list. The microscopic metaplasia over here, further up or more cranial on the esophagus towards the head, we actually see stratified squamous, which is what we would expect. And as you migrate more distally, you can appreciate the red arrow. This is pointing to goblet-containing epithelium. You can see these white open vacuoles. Those are goblet cells. What do goblet cells do? They secrete a mucus, and that creates a lining, a protective lining to protect that epithelium from the harsh environment of hydrochloric acid. Okay? So more caudally or downwards towards the tail, those are just orientations of anatomy, right? So more toward the tail, closer to the stomach, we're seeing metaplastic changes of goblet-containing epithelium. And this is a biopsy. You come in, you take a piece of tissue out, you run histology on it, and these are the kind of conclusions the pathologist is looking at. And that's why we take samples of tissue, because we can see at the microscopic level what exactly is happening. Pretty clear, right? All right. So in Barrett, what do we got going on? And when does the cancer become really problematic? Well, we've got the alteration of cells. We've got cellular metaplasia. There's no question about that. But at the level of prolonged injury, the question that we have is, are we influencing the stem cells that line that epithelium? Because those stem cells or those progenitor cells, those are the cells that are responsible for giving rise to new tissue. So let's talk real quickly. What are stem cells? Let's pause for a moment. Now let's hear from you all. What is the knowledge in the room, or where are your guys' heads on stem cells? Or what do you recall from some of your previous coursework? Back here. Undifferentiated cells. Okay, I like that. Anybody else? That's it. We're going with that. That's it. Mother of all cells. Okay, I like that. Mother of all cells. Stem cells. What's that? They're non-specific.
Adding to that, they have specific pathways.
They have specific pathways that they can be pushed down.
Yes.
So the word undifferentiated is a word that means that the cell hasn't had its fate determined yet. So you guys remember back to 201, you talk about skin, the integument? And what was the layer of the skin at the level of the epidermis, the outer layer, that was the stem layer? The layer that gave rise to new layers of skin. What's that? Strata, just layer what? Basali, very good, right? That basement layer. The stratum basali is the deepest layer of the epidermis before it gets to the dermal tissue. That stratum basali layer is the one that would turn over, right, and give rise to more superficial layers of the skin. If you have a basal cell carcinoma, what layer of the cell is that cancer? It's the stratum basali layer, right? And a basal cell carcinoma is a very aggressive type of cancer. It's very dangerous because you've actually caused mutation at the layer of the stem progenitor cell that gives rise to the rest of the skin. Okay? So all tissues in the body, for the most part, all tissues in the body have some sort of progenitor cell, have some sort of stem cell. Like muscle tissue has satellite cells, right? Skeletal muscle has satellite cells. It gives rise to new muscle tissue. Adipose tissue, fat, has lots of stem cells in it. So if you've got a cancerous mass and it causes a mutation in a progenitor layer, in a stem layer, that's where it becomes extremely dangerous. Because now that mass is going to grow and everything that comes out of it is going to be mutated or cancerous. Okay, so let's talk about other types of stem cells. So we have two main categories of stem cells. We've got adult-derived, which is what we've been talking about, and then we have embryonic stem cells. All that we're talking about really in this class is adult-derived stem cells, after the individual is born. But embryonic stem cells exist in utero, correct? And say a decade ago or more, they were the subject of tremendous controversy, because if you harvest embryonic stem cells, they have totipotency, meaning they can become any kind of cell in the body, but it's at a cost, it's at a price. That organism is going to be sacrificed in order for you to push those stem cells down a lineage. Adult-derived stem cells don't have totipotency. They're usually what's called multipotent or pluripotent, meaning they have many different potentials they can become, but they can't become an entire organism like embryonic stem cells. So when we talk about cellular metaplasia in cancer, we're referring to totipotent, we're referring to multipotent or pluripotent adult-derived stem cells and tissues, not embryonic. Make sense? Okay, so as we get back to our Barrett esophagus example, our first clinical pathology that we're going to talk about, nobody raised their hand and wrote Barrett on their list. It's not one that's a super common or popular, although someone's grandfather is wrestling with it. Maybe it was on your list. Was it on your list?
No, I actually didn't think of it.
You didn't think of it. You could add it. You could add it. It's fine. Okay. So this is one of the reasons that I picked this one to dive into on day one. You know, it's just a great example. There's a lot of information there, and it gets us thinking. It kicks off the way that we think. So if we think about some of the clinical features of Barrett, they're as follows. Usually, they're 40 to 60-year-old males, mostly Caucasian descent. Okay? There's a localized ulceration that's occurring at that level of prolonged injury, bless you. And clinically, the definition, if there's more than 3 centimeters of this Barrett-style mucosa, meaning that you've got this cellular metaplastic change, then that individual is 30 to 40 times at greater risk of developing esophageal adenocarcinoma. And how do they determine that there's greater than 3 centimeters of Barrett mucosa? Right? They look with a scope down the mucosa, and they might take a biopsy at certain locations to determine how prevalent is the metaplastic change. If it is untreated and left to go and progress, it advances to what's called a dysplasia. And the word dysplasia is from the ancient Greek meaning difficulty. And this is referring to abnormal cellular growth or development. And this gets it much closer from metaplasia, which is reversible. A dysplasia is non-reversible and is one step closer to being cancerous. So a dysplasia would be kind of that precancerous tumor that wasn't quite malignant yet. Okay. The last example that I want to show is just in a slightly different part of the body, where we've got similar types of problems happening as Barrett. Okay, this is at the level of the duodenum. So instead of the inflow, this is at the outflow, right? So we're talking about the lower esophageal sphincter. We're talking about gastric juices moving retrograde back up and creating heartburn. Now we're talking about the duodenum, the beginning of the small intestine, and we're talking about stomach contents empty. Question?
Can it skip the dysplasias? Is it like a this, and this in terms of like transition from healthy tissue to metaplasia to dysplasia to cancer? Or can it go from straight from metaplasia to the carcinoma?
Yeah, so the question, I'm just going to repeat the question for the video and also for the people in the back. So the question that came from the front of the room is it always a sequence of events where it goes metaplasia to a dysplasia to a cancerous form? And the answer to that is it typically progresses, but the time frame might be very, very short, depending upon the individual. And so depending upon how closely you're monitoring things, you may not see every single transition zone. And again, these are, in this class, in all biology, it's notorious for this. This is what we call it. Do you think the cancer cares what you labeled it? No. That's just how we define it, okay? So we've created these buckets and these labels. The cancer does what it does. It doesn't care what the label is, right? But for the most part, what we've been able to identify are there are these different phases, but how much time they spend in each phase is dependent on the individual, okay? Yeah. Okay, now we're on the emptying side, and this is an ulcer, which is not very different than what we saw more cranially, or more towards the head, when we're looking at the lower esophageal sphincter interface with the stomach, and gastric emptying, but in a retrograde fashion. Now we're talking about normal gastric emptying, but there might be an excess of HCl. It may empty too frequently. What are things that can influence that? Well, there could be all sorts of underlying challenges that can influence that. And stress could be one of them. Okay, stress causes an increase in corticosteroid production by the adrenal glands, and that influences all sorts of metabolic processes in the body, including gastric emptying. And so if the gastric contents are going out too frequently, stress levels are too high, that could create an ulcer in the small intestine or in the duodenum. Okay, so we're looking here. This is an example from the DVD that's in the bookstore. So this is an example of how I would use this histology. Any of these pictures that you've seen today, okay, probably not the one with the cute little mouse, like with the stuffed animal, but it could be. But any of, or the fishing pole, like teach a man, we're so beyond teach a man to fish, right? Right? You're like, oh my gosh, we're just so, all of a sudden we went from like fishing and Chinese analogies to this, right? So all of these pictures are fair game for the exam. But this is kind of an example, like these last few clinical examples are classic examples of what you might see on the exam. Okay, how I would show them is just like what you're seeing on the screen. You have a question about them on your exam packet. Okay, so let me get through this and we'll take some questions. So here's our normal stomach duodenum with a Peyer's patch, right? So this is the lumen. This is technically outside the body. You guys with me? You consume things, it goes into the stomach, it stays outside the body. You chemically digest, you mechanically churn it. It isn't until it crosses across the epithelial layer that it's really been absorbed into the body. So this is outside the body, so this is actually Peyer's patches. These are immune tissue that lines the inside, kind of like sentinels, saying, okay, I'm evaluating what's coming across. So this is normal Peyer's patch. That's what you would appreciate, or you would expect. You can appreciate it too, but you can expect it more likely. And then you can actually see the imaginations of the epithelium of the stomach duodenal interface. And then here is a chronic peptic ulcer. No Peyer's patches. This is chronic inflammation, right? You've lost the architecture of this increased surface area due to these foldings, right? The villi and microvilli, that's gone. There's nothing there. It's actually tissue that's sloughing off because this is all inflammatory granulation tissue, and we have no iris patches. Okay, so we're seeing metaplasia here as well. We're losing iris patches. We're losing the architecture of the duodenal interface, right? Absorption is compromised. We have massive inflammation here, and we have tissue sloughing that's not supposed to be taking place at this rate through this interface. You slough off your intestines just like you slough off your skin, right? And then it turns over about every 6 to 8 weeks at about the same frequency as the skin. But this is happening like on a daily basis. Look at this. See this friable tissue, how this pink tissue is dissociating? It's supposed to be nicely attached like this. And this is very, very pathological. Okay? Question?
So are you going to want us to identify all the different features of these histology slides, or just like the most significant ones, or what?
I'm gonna on these pictures, on the histology or the gross pathology, I will use them to ask questions over content that we've reviewed. It may not be a what is this yellow arrow pointing to? That's a little bit more 201, 202. You know, it might be. Let me try to make one up. Okay, so it might be in this clinical example of Barrett. Which of the following is happening at the red arrow? And there'll be some sentence that you'll have to choose between, A, B, C, or D, or E, right? And so I'll be asking you pathophysiology questions about this slide. I'll say Barrett, I may not say esophagus. This is esophagus tissue, right? You with me? But if you're here listening, and you're walking through this, and I use the word Barrett here, I say this is a Barrett disease, what's happening at the red arrow, you should be able to answer that question. You with me? Okay. Does that help?
Yeah.
Okay. So it's less about like label all the structures here. Like that, we're so beyond that. Right? Anything else? Any questions? Okay. We're done 2 minutes early. You guys have been so wonderful. Take next week off.